Welcome to the September Wandsworth CCG board meeting. Ian, are we camera rolling? Just to remind everybody, we're on video. So I did just have a list of apologies, and it's disappeared. What did it? I don't know. Can you tell me who was on that list, please? Huda.
Huda.
Yeah. Julie.
Yeah, Julie has.
Yeah, Julie's apologies. I'm so sorry.
Jonathan Chappell.
Oh yeah. Okay. Thank you.
Chair, can I also let you know we've just had a late apology from Dr. Waqar Shah, who's
indeed,
yes. Unwell.
Thank you. Yeah. Good. So, any declarations of interest that we need to note, particularly for this meeting? More. Thank you. And we are indeed quorate. We're many in number. So, what should we say? I hope everybody has had some downtime over the summer. I think work has progressed in spite of the fact that everybody's taken holiday, but I hope you all had some relaxing time with family and friends and are raring to go again for this stretch. You know, the NHS coming up to winter always feels like a really important time to me. We have had some really good news locally. So Kingston Hospital had their CQC report in, and they've got some elements of care which have been rated as outstanding. So that's very good news for our patients who attend Kingston Hospital. Really great. Right, shall we get on to the minutes of the last meeting, which was our July the 4th meeting. Any issues of accuracy on that from anyone? No, thank you. And were there any actions?
Yes,
there was one for James, yeah.
Okay, so the action was in relation to the health and social care integration item, and it was around looking at how we work as we're building our approach to health and social care integration on the experiences of residents from diverse communities. I think there's two strands to this. Firstly, we are continuing to be involved in the co-production reference group, which is the group of organisations across Wandsworth that looks at opportunities for further co-production opportunities and different ways of involving communities, and we're continuing in particular to work on the focus area around tuberculosis and latent TB diagnosis. I think the more substantial item around this is that we're now organising what's being called a deliberative event as part of our Wandsworth local health and care plan process, and this is being organised for November, and this is going to be an event to basically share the outline priorities for the local health and care plan and get very wide-ranging involvement in taking those forward. And amongst some sort of 180 people that we're looking to invite to that event in November will be a very wide range of members of local communities with an explicit focus on having a discussion around how their experience of services influences how we take forward areas such as health and social care integration. So I think we've got a really great opportunity through that event to really get a very broad-based understanding from our local communities about their experiences and how we need to reflect their experiences, and not just involve and engage them, but also really co-produce with them in terms of how we take this forward.
Very good, thank you. Yeah, Carol.
Are board members meant to be there?
Yes, but not necessarily in a board capacity, but in a variety of other capacities. So we're working on the invite list now, and invites will follow shortly. Yeah.
Do we have a date?
Is it the 20? Are we confirmed the 28th, Jen? For them?
Almost confirmed. It will be confirmed in the invitation.
Yeah.
But that looks to be the date.
Yeah, it looks like it will be the 28th of November, but we're not just not 100% sure yet.
Thank you.
Good. Excellent, thank you for that. So, and just before we, items for any other business. Does anybody have any that they know of? No, thank you. So before we get cracking on the agenda, I just wanted to say welcome to Katie Denton. So Andrew McMyler who was, I never remember his title because it changed a lot, but he was Director of Primary Care and Transformation of late, and of all things really. And so Andy is taken a secondment, so he isn't here today, and I didn't know he wasn't going to be here today. Actually, I hadn't clocked that he was on leave. But Katie Welcome, who is standing in for Andy, who's technically on holiday this week. So I would normally have said something about Andy, but he's not here, so it's a shame to have a prod if he's not here, really, isn't it? And I don't think he'd be watching. Are you watching? I don't think he's watching. I really think he should have been. So, I'm not quite sure what to do. I think maybe we'll have to think about how we say thank you to him properly. But, a sort of a formal thank you very much from the board, because he was, I think, our probably last remaining of the original exec. Would that be right? I think so, of the founding kind of board, and he's been with us all along, and has done some really great work, and I know his team will be really sorry to lose him as well. He's been great as a line manager, so I had lots of nice things to say about him, but it's kind of a shame if he's not here, but maybe I'll say them directly to him or make a video and send it to everyone. Good, okay, so let's move on to the agenda then. So we're going to talk about the Health Innovation Network and have an update from Dr. Natasha Curran. So Natasha is the medical director for the HIN as well as being on our board, and we thought actually it would be really important to understand what the opportunities there might be for us in Wandsworth working with the HIN and to really understand what they do. And we have had updates about the HIN before, but I think getting it from the horse's mouth would be really great. So Natasha, do you want to set off?
Do it the other way. From the beginning. Okay. So my mic's on as well. Thank you. So just so the horse's mouth has only been in post 2 months. Okay. So please don't ask me too many difficult questions, but I will be able to get back to you on anything that I don't quite. I'm not able to, but hopefully I'll be able to give you a good oversight. I'm going to assume no knowledge. Okay, about academic health science networks. So AHSN network. So the Health Innovation Network is yours, as in South London's Academic Health Science Network. There are 15 academic health science networks across the country, well, across England, and they came into being 5 years ago. And they're roughly based on populations and STP. So South London being South East and South West. So the Health Innovation Network is the academic health science network for not just us, but South East as well. So that's 12 boroughs. And they came into being really because whilst pockets of the NHS create great, parts of innovation, other parts of the system may not know anything about it. And we're quite slow at adopting things, and we have, because of our national bodies and organisations like the Academic Health Science Networks, it was thought that there would be a better way to try to identify what's new, what's exciting, what's improving health and reducing costs, and spread that around from one part of the system to another. Okay. So, specifically they're all called different names, by the way, so which can be confusing as well. So, although we're all academic health science networks, the HIN, or the Health Innovation Network, is South London's. And just to extend that, so we connect academics, commissioners, providers, which are acute and sort of private, patient groups, industry. And the industry is something that perhaps I hadn't been quite as aware about. So we cover in South London 3.5 million people, and it's a member organisation. So Wandsworth, like the other CCGs, the boroughs, are members, and we hope that we catalyse some of and support changes across the system. And we also need you to know about the HIN so that we can do that. So that's the footprint. So if you like, obviously Wandsworth's there in the grey, and so just to show the kind of it covers third sector primary care, acute trusts, mental health trusts, and everyone in between. Okay. And I think most people think about academic health science networks as improving lives, but perhaps not so much about the saving money, although value is always something we want to do, but actually driving economic growth as well. So we want our small businesses in London and beyond to benefit in health, because that drives the economy and is good for Britain. Okay. Because we also have the opportunity to create wealth within the health system in that. Okay. We have many themes, so the ones across the top are probably much more obvious for clinical reasons, so things like diabetes and stroke prevention. We've just appointed a new clinical director in mental health, which I think ties a lot of the SDP and actually Wandsworth priorities at the moment. But musculoskeletal health, patient safety, digital health. But things across the bottom are perhaps actually where Wandsworth as a member could leverage more, more from the HIN as one of its members in terms of capacity building, change support, for example. Okay, so this is just to show some little series of impacts in recent projects. For example, in diabetes, what the Health Innovation did was able to increase insulin pump usage appropriately. We have a scheme which helps good graduates match into NHS jobs in London, sort of leveraging income or investment for small businesses and other companies, I suppose, in health and so on. Okay. So I just want to give you some examples which will make it seem real. So escape pain is something which is an innovation. And innovations don't have to be kind of like, really technologically advanced or, sort of bits of kit which are very expensive. So escape pain is a behavioural management programme for people with osteoarthritis, which is education and exercise, which improves outcomes in terms of pain, functional ability and so on. It started in George's and it's so successful that it's now become a national programme. Okay, so Wandsworth patients have access to escape pain via George's and other hospitals locally, and it's something that's we as Health Innovation Network now are spreading out around the country. So there's 80 sites live now in the country that do this. So I've been told that the pharmacy in Wandsworth is really supportive and active and fantastic around medicines optimisation. That's a community of practice that the HIN is establishing and supporting lots of the things that you, particularly the general practitioners and pharmacists, will be doing around polypharmacy and in care homes, for example, and also when patients transfer from one part of the system to another. I wanted to let you know about some sort of bringing diverse partners together. So Serenity Integrated Medicine doesn't really tell you what it is. This started in the Isle of Wight in response to a small number of mental health patients who are very severely unwell, using up a huge amount of resource and actually not getting good service themselves. So a huge number of resource in terms of police time and assessments and mental health times, and actually being hospitalised. And the intervention there, the innovation, was putting a police officer together with a mental health nurse and together assessing and going to these patients. As you can see, that's a bit messy, but what you can see is the increase in costs, as it were, and not just cost, but time that patients were staying in hospital. And then actually after the intervention, when this service started working, then that reduction. So, good for patients and good for the healthy care economy, and no doubt is very good for staff as well. So that's now going nationally. So we're doing that now in Wandsworth. The HIN also tries to support things across the SDP. And I was at a workshop yesterday actually about evaluation, and there was representation there from each of the boroughs in South West London. It's really thinking about how we can support the evaluation aspects of primary care at scale, for example, online and other types of primary care at scale. Okay. There's been, I'm sure people are aware of that huge transformation for diabetes that's happened. This is not just to do with the HIN, but many other initiatives as well. But the HIN has really supported particularly the structured education aspect for patients across South London. So it means that if you're a Wandsworth patient, you can do a course in another part of London, perhaps where you work, for example. And things like just putting together teams of different professionals to support foot care, which sounds like it might be simple, but actually as a partner organisation we can help that. I thought you might recognise this character. I know that everyone's aware of the red bag scheme now. There's Andrew, Merton's chair. But not just the red bag scheme, which has helped care home residents have a much smoother transition in and out of hospital, but we've trained care home managers as pioneers to provide them leadership so that they feel much more empowered to help across the system with their residents. Okay, and we're working on an end-of-life care programme across the SDP as well. The Academic Health Science Network also hosts this innovation accelerator, because it's quite, if you're a clinician or anyone else who has something you think might be useful, it's pretty hard to get that floated into the system. So the NHS Innovation Accelerator tries to do that, and there's cohorts every year. We're about to go into our third cohort now. London also hosts a digital accelerator. Okay, that's supported by all of these partners. And the cohort's assessed on three main criteria, really. There needs to be a need for it. It's great having a gizmo, but does it actually do something that needs to be done? Will it create a good business? And will it benefit from the programme? Some things are quite advanced or not ready enough for the accelerator, for example. And this is just to illustrate what, if you're a small business, that you might go on this journey where you end up having support to transform your idea and your small innovation, if you like, into something which is much more marketable and scalable. I just want to give you an example of this, which you might know about, which is called Dr. Doctor. This is a digital platform, if you like, which can reduce waiting times for patients. And patients are much more empowered to use it, and it saves the acute providers financially as well. And that's now backed by NHS England. This is just to let you know how many different types of small business can be supported, and the range of things that they might do. So the next 5 years, Academic Health Science Networks have been licensed now for the next 5 years. And with that, we've got national programmes. So you'll see the escape pains on the list. So that's one local thing which has gone national. So therefore, we also have to accept things from other areas. I've explained to you about Serenity Integrated Mentoring, which is with the police officer and the mental health nurse. But there's other things around atrial fibrillation. Precept is about reducing the morbidity for preterm labour by giving women who are eligible magnesium, so their children are less likely to have cerebral palsy if they're at risk. For example, emergency laparotomy collaborative, mainly in acute trusts, for example. Okay, so I just wanted to highlight one of them, which, because there's some things going on in Merton and Wandsworth that I thought would be useful for you to know about. AF, a lot of people walk around with AF without realising it, and therefore they have strokes. And so there's two arms to the programme which are about detecting AF and then treating it. So the national programme wants to detect an additional 130,000 people with atrial fibrillation, and then to provide them with appropriate anticoagulation. And this will prevent about 4,000 strokes and save about a quarter of their lives, and save money to the NHS overall. So in Wandsworth particularly, some work which is going on right now, we're working in care homes particularly to increase the number of patients that have coordinated my care plans. And hence also the diabetes, the book and learn, so patients can directly book their own diabetes self-management programme education, launching in October. I think I just mentioned about the primary care at scale evaluation workshops that are happening, and social prescribing. The HIN's been helpful in training other people in Wandsworth, so not just GPs but other people in the practices, so they might be able to direct patients to other services which they may be able to use. And the AF detection scheme, just to let you, the detail on this is just to show you how many kind of these little devices which you can see or not, you put your fingers on, so they're not the same as a full electrocardiogram which you might get done in a GP surgery or a hospital, but they can direct people then to have a more formal test. And just to show you that they're now being trialled in GP practices, by nurses on domiciliary visits, and in different places like activity centres and health shops, and in mental health trusts as well, where people may not feel as willing or able to go into a hospital setting, but may be happy to have their test via their fingers there. So I think that's just a flavour, really. And I'm very happy to take any questions and take questions elsewhere if I can't answer them. Yeah. So.
Excellent, Natasha, thank you very much. I'll tell you a story about the...
I wondered whether you'd like to.
Those of you who know me will know I love this little gadget that you put your fingers on and it tells you whether or not you've got an arrhythmia. So 2 things happened. One was my husband ended up with an echo and a 24-hour ECG, which subsequently turned out to be normal, thankfully. So don't use it when you're nearest and dearest. And then the other thing was I took it to... We set up a project at the First Down project. Where we have lots of elderly people who come together really to tackle loneliness, but they come together several times a week to do physical activity and that's like a community group environment. So it's a fantastic place to just go. If ever you have the chance to go there, just go and spend the morning there. It's brilliant. But all these folks were bussed in to come and have their usual exercise class, and they were asked whether or not they wanted to have their heart rate checked as well. So we explained it all to them, and I was watching the people who were doing this project, and it was great, really well received. And we did pick up one person who had an abnormality, in fact 2 people, so one we don't know the outcome yet. The other one though was quite interesting. So this chap who was there for his first visit, and it looked like he might have atrial fibrillation, but I looked at it and there's a bit of added value, a doctor being there on the day, I think, which might not normally happen. But then what happened, out of his pocket he took his packed care plan that his GP had done for him. I was just awash with joy, really. And it showed that he'd previously had an arrhythmia which wasn't atrial fibrillation, but it meant that we could explain to him what we were picking up. So, this is fantastic. There are big issues with doing these kind of projects. You can get false negatives and all that kind of thing, but on the whole it's been really well supported by the HIN to do something which we weren't able to do before. It's really great. So that's kind of my experience of things. So just broader issues and questions, Chris and then Sarah.
Firstly, thank you for that very informative presentation. I mean, it's useful to get behind the labelling and the terminology. A long-standing criticism of the service is it's very slow to adapt, it's very slow to innovate. So, in a way, anything that can speed up the rate of adoption. And I suppose this is the thing I was going through my mind as I was looking at all this. And there is quite a lot being potentially going on. Your poor practitioner, whether it be a GP or in a hospital environment, could feel as though they're slightly overwhelmed with the scale of changes that are going on, much of which is enabled by the whizzos, the gizmos, the technology, and all the rest of it. So I suppose my question now is, presumably the objective overarching is to try and speed up the distribution curve, the classic distribution curve being a small number of early adopters, a large rump of adopters when technologies or solutions are proven, and then the stragglers, the people who, for one reason or another, are slow to change, don't want to change, don't understand, and whatever. So presumably this whole initiative is designed to change the distribution of that curve. Is that right? Or is that too simple?
Well, in part, I'd say absolutely. I think one of the things that NHS clinicians suffer from is not being able to, not able to look out and see these things happening in other parts of the world. So other people have to bring them to show them, and also to give that capacity. If you're a hard-stretched clinician, clinical lead, general manager, and that's one of the other things that the HIN tries to do, is to enable capacity. So if you're working at full pelt, how are you also expected to do the change management around that as well? So I think that's part of it. And I would say that the academic health science networks, our responsibility is actually to give some balance to those things as well, so that when we check that they're evidence-based as well as they can be, there's always a tension between how much evidence and how quick you can be, because if you wait for everything to be really well evidenced then. So it's actually about real world evaluation. And of course, in the real world, places have different local systems, which mean that X may not work as well for whatever reason. And that, so some of the things on the accelerator, for example, when they're not eligible for use in South London because some of things in South London are too good. So that's a very strong reason not to be bothered about that. So it has to have some intelligence about how. I think that's probably what my key role actually is, to try and be that moderator. Does that answer all your question? Yeah.
Sarah, because Sarah, you're on the board of the HIN, is that right?
Yeah. So I'm on the board. Sometimes I cannot attend, but Karen Broughton, who's our Director of Strategy and Transformation for South West London, attends on my behalf if I can't make it. And Jacqueline Totterdale actually does attend as well, Chief Executive George's. So there are a number of us on the HIN board. My reflection on it is that a lot of the work that the HIN are doing are around the digital elements that are coming into the market, and they have a very strong relationship with business, and that is their kind of focus. And they are, although we are members and we do pay a small amount of money for that privilege, actually the majority of their funding comes nationally and is around them developing that business model with local businesses. And it's very positive, but also we do need to be careful that actually we're not pushing some areas that maybe aren't the right areas. So we're now linking that up into the digital work across London, and luckily Karen Broughton, who attends the board, is also our digital lead for South West London. So she's trying to link up with all of that work that's going on. What I would say is that there is some really good stuff that they're helping us with, but and there's also some work that we've done that started in South West London and then the HIN have taken on. So the red bag scheme that was picture of Andrew Murray up there, that started in Sutton. You will all know that Sutton were the leads for that. They developed that and we rolled it out across the whole of South West London, and the HIN have now taken that up to take that nationally. But and actually it has been taken nationally by NHS England and is being supported nationally. So there is something about their role in spreading good practice, but often that comes from us rather than from the HIN, and then they take that on and help us to spread that good practice. And then the other bits are, what can we take from what the HIN works with business in order to take into our local systems. I think we need to build the relationship. I'm not sure we've always got the benefit of that locally, and I think now with Karen and I involved in that, we can start to link it up, particularly with the digital. Just to give you some assurance, Escape is part of our MSK pathway across South West London. The SIM, I meet with Sally Benatar, who's the chief, the borough commander for the whole now. She covers about 4 or 5, including Wandsworth boroughs, and we're doing SIM in South West London, so we are delivering that with the Mental Health Trust. That's been something that we have done locally. So a lot of this work that we're talking about, we're already delivering in South West London. So we are kind of ahead of the curve on some.
Oh yeah, I wouldn't want anyone to get the impression that South West London is not doing these things. It certainly is.
We're kind of ahead of the curve on that.
And also that, to reiterate that point, is that as a member, I think what Wandsworth can do more of is be more demanding, and say, well, I've got this idea, or my clinician's got this idea, or and bring that forward.
Good, thank you. Roo and then Carol.
Yeah, thank you. That was really, really informative, actually. You mentioned primary care at scale, and I just want to know your involvement. You talked about evaluation.
I thought I'd get caught out here.
Yeah.
Go on.
It's just that you mentioned about evaluation, but I wondered whether you'd be involved in sort of design and implementation, really, just because we've struggled sometimes to work out.
I guess it depends what aspects, because one of the things that we were doing yesterday was giving people tools and skills so that they can do, because there's a number of aspects about that, and whether things are core services or whether it's e-consultation. So, giving people the tools to say, well, what are you actually trying to measure? And I could take a long time to go into it, and how will we know that that's been successful, or how will we know that we've achieved our objective on value on something? So there's several things that the HIN interfaces with Wandsworth on primary care, and at primary care at scale, what we've in South East London, for example, we've done much more about, it wasn't exactly a community of practice, but more about sharing, whereas this is, so the focus in South West London has been more about how we're going to evaluate the things that because lots of ideas come up, primary care itself will know, as we're going to, what things it might want to trial, how we're going to evaluate those really well. And the HIN does do some consultancy work as well, so it's able to do that on behalf of members or as a separate piece of work.
Sarah, did you just want to say?
Yeah, so we get most of our support around primary care at scale has come through Healthy London Partnership. Actually, that's where the link through is for the primary, and the money that we have got and we're delivering all the local work is through the HLP and through our South West London transformation. I think where the benefit comes from HIN is around, again, those digital. It's mainly around things like what's the impact of, say, some of the digital things that we might do that support primary care at scale. So I think it is that partnership across the system of what we do locally, because we do a huge amount that we actually just do ourselves. There's the bit that we get through Healthy London Partnership and how they support the models and what we do, and then also HIN has a role in that if we choose to work with them on that, to particularly, I think, around maybe some of the technical stuff and the evaluation rather than the strategic and developmental stuff which has been coming through from, and they have slightly different roles, and I think we need to be careful and just make sure it all joins up somehow in a way that makes sense.
Good. Carol.
Thank you, very interesting. You mentioned placing 40 graduates, I think.
Not quite as many as that, but
Anyway, graduate placement.
Yeah.
I'm interested in that. Where do they come from? Where are they being
Yep.
placed? What scope is there to expand on that across other groups?
Okay, so this is something that is particular to South London and the HIN. We saw an opportunity that there's lots of people that don't make it onto the NHS graduate scheme, but are great people who'd be great for lots of roles. So, if you like, we act as a dating agency, member organisations. So we've got these jobs available, and we'd like some of your some NHS graduates some graduates to come into them. So we have the ability we have a connection where we have. I'm not quite sure how the data's worked out, but we can contact the people that have not been successful in the NHS graduate scheme and offer, if they choose to, then we can offer them place, or as a dating service, if you like, with the organisations of South London, and we're now expanding that to North and West London as well. So it's because I think that there are a lot of vacancies in member organisations for good people, and actually that there's a kind of disconnect with matching people.
Good.
Is that
okay? I probably need to move things on a bit. So I've got Sam and Stephen, and then we're done. So Sam.
Yeah, just briefly. I was just really interested in the link between implementation and evaluation, because often the difficulty with replication is not actually about does the evaluation show that it's about how it's implemented, and there's a lot of work going on in things like the Early Intervention Foundation about what does replication mean, and how do you do that, and what matters and what doesn't when you're thinking about replication. So presumably the change management part of what the HIN does thinks about replication and scale.
Yeah, so there's two aspects about that. There's what, for example, if you're thinking about escape pain as an example, there was like, what is core and what can we change? That was something that was thought about. So actually, we don't want people to be rigidly sticking to something which is therefore not relevant in their local area. So what are the core elements, which would mean that you don't change those? Therefore, because the danger is then, isn't it, people scale away at things or take away at things, and actually you're not doing the intervention which was shown to be beneficial.
And then get surprised when it doesn't work.
And then it doesn't work. But you have to be responsive to what's happening locally. The other part of your question was about how do you, I think what you're asking was how do you evaluate implementation. Is that right? So that's one of the things that HIN might do in terms of real world evaluation, is like say, well, let's take one of those other programmes, let's say SIM for example, how's it being evaluated, what's happening in South London now that we've taken it from somewhere else and put it into there, so what are the impacts there?
Good. Okay, thank you. Stephen, last one, I think.
I just wanted to ask whether the voluntary sector has a role here. I'm conscious that the voluntary sector also often feel that they have ideas, initiatives that would be helpful, but find the NHS as an entity almost impossible to deal with because it's so sort of amorphous and big. And also the voluntary sector struggles also, like small business, with operating at a small scale. So how do you get scalability? Is that a dimension of innovation that you are sort of open to, as it were?
So in a word, yes. When I sort of look at the board and the programmes, I think there's more opportunity. We partner with the Alzheimer's Society, and I guess it depends whether you mean about volunteer or charity as well, because there's crossover and they're different things. And also actually how one partners more with patient organisations. So Health Watch are one of our member organisations, but I think that there's more we could do there, to be honest.
Okay, good. Yeah. Excellent. So, Natasha, thank you very much. That was really, really great. I think it's been really important for people to hear about this, and we'll think it'll be more on our mind as to how we integrate the work we do in Wandsworth with what you're doing, and it'll be more familiar territory now. So I think that was very useful. Thank you. Excellent. So let's move on to commissioning intentions. So it's that time of year. Josh, do you want to give us an intro on this?
Yes, so I've only got 10 minutes. Turn my microphone on, have I? Sorry. Thank you. The gesture of turn it on, right. Sorry. Sorry for those of you at home who missed it. I can do a little video afterwards for those that missed it. I've totally lost my flow now. Yes, so as part of that, it was decided, however, that whilst the Health and Wellbeing Board's role in setting the direction and the areas of priority was right, we needed a body that would be a collaborative of all of the commissioners and providers across Wandsworth to lead and deliver that work, and that is the Wandsworth Transformation Group. So the slide deck outlines the priority areas within the local health and care plan delivered by the Wandsworth Transformation Group, but also outlines other work that we're doing via things like the Planned Care Delivery Board, the Emergency Care Delivery Board, the Mental Health Network, and so on and so forth. So I'll probably leave it there in terms of introducing the paper because of time limitations, and open to questions or comments. As I say, this is for discussion, and the one thing I will say, so the commissioning intentions letter, the next steps for that is it will be signed off finally by the committee in common in October. So any comments around the content of that today is great, but also over the next few weeks as we get to final drafts. For the commissioning intentions and our commissioning plans in general, that is an ongoing development, but contract negotiations and business case development will start mid-autumn into the winter. So again, any steer or comments you've got here would be great, but also your ongoing engagement and leadership in this area will be very much appreciated. Thank you.
Helpful to have that. So, questions and comments, and Stephen, start. Thank you.
Thanks.
I welcome this. Excellent. I had one question to a comment which I alerted Josh to. If you look at page, I'm looking at 67, but it happens on several pages. There's a column called impact of all these various things, which in this particular case says reductions in A&E attends, short stay admissions, LAS conveyances, and those words or variants on them run right through it, and those seem to be absolutely the right objectives. But as drafted, I think it is sort of probably misleading even. I don't think you mean reductions as in the numbers will actually fall next year or the year after. I think you mean something more subtle than that, like it might not rise as much as it might otherwise have done, or things will be capped or something. So I think we need to be quite clear, particularly as it's aimed in part at providers, because if I was a provider reading that as it's drafted, I would say, oh good, so we can scale back on A&E, for example. I don't think we really mean that, do we? Or it'd be great if we did.
So it will vary a bit programme to programme. I think a more accurate description in some of this would be to reduce the rate of A&E attendances or admissions. We have seen in the past, though, examples of where that reduction in the rate and a real terms reduction has happened. So, elective procedures, for example, for musculoskeletal conditions in Wandsworth have dropped in real terms over the last few years. As a result, actually, just linked to the previous comment around MSK, we have also seen a gentle reduction in other areas of emergency medicine as well, in real terms as well as the rate. So they're in here as an early indication as we expect these pieces of work to have a significant impact on the demand for these services. But you're right, in some cases that will be constraining the growth that we would see if the work wasn't otherwise there.
Good. Thank you. Chris?
I also welcome this. I think it's an excellent document. What I want to understand more is earlier this year the government announced their intention to significantly increase the amount of money that the health service was getting. There was a big statement, I think, in June, July time. And the Treasury subsequently made clear that this additional funding was conditional upon the NHS providing a plan which would demonstrate effectively how the extra money was going to be used. Now, how does this document relate to that plan?
Sarah?
So we are awaiting currently the National 10-Year Forward View, which will set out the NHS national direction, which will support the release of that funding into the NHS. There are 11 work streams, which if you look on the NHS England website, they will tell you what they are, but they would be as expected. They are primary care, mental health, and so on, A&E. The expectation is that most of the money that will be released will be allocated to either new pieces of work or to, so we do know the pay uplift that's been awarded. We think that will be included in that uplift, so that will take some of that money away. And then we are expecting to have to achieve more in things like our planned care, our mental health, and so on. So we know Green Paper on children, young people, mental health, there'll be additional funding in that will take up. So what we will need to do, and they've been very clear about this nationally, is that we still need to work efficiently and in a productive way around the existing funds that we have. So we're not expecting to get a whole load of money to cover any existing financial problems that we might have in the system. So therefore what our commissioning intentions then do is make sure that we have a sustainable position based on what we are currently doing and how we might change and transform services locally. So I don't think we should rely on that additional funding coming down as a kind of answer to any financial issues. So I think that's an important message for us as an NHS, and I think when we get the 10-year forward view and the planning guidance that will follow on Christmas Eve, then which is always our present from the national team for Christmas, that will become clearer, and we'll make sure governing bodies have all updates on that as soon as we receive it.
Could I add to that? So where there are some direct links in some of our commissioning intentions and some of the emerging policy, although as Sarah says it's yet to fully emerge. So for example, Wandsworth along with Sutton and Merton are applying to be a trailblazer site for children, adolescent mental health and developing mental health around schools. That that is something that will be in the
Yes.
plan. It definitely will be,
Yeah.
and so we're putting a lot of energy into being part of that bid, and hopefully we get selected. Yes, so there are elements in here which we're sure are going to be in the policy. I won't start talking too much around mental health because that's what Tom and Mark will be doing later in the agenda.
Cool. Okay. Thank you, Josh. Can I just flag a couple of things? Firstly, to say I think it works quite well to have this South West London, a sort of more traditional formal document, and then the Wandsworth kind of more lively. It sort of separates them, but it's comprehensive but digestible. I think it's really shaping up well. So thank you to you and your team for that. Just a couple of things I wanted to mention, and perhaps I'll pick up with you a bit outside. There's something in here, and it's in the South West London document, but thinking of audience, I think we might just have to think about how we phrase it. It's about GP demand and capacity planning with reference to how that might potentially offload the urgent care system. I think we might need to think about how that is. Firstly, it's very difficult. We wouldn't know how we're going to do it at this point in time, and so the language around that might need to be quite careful. The other thing, just to flag, is on page 92 of your slides, what residents tell us. So I suppose just to call something out which people have said. So continuity of care is really important for people in Wandsworth. I can absolutely see that. Accessibility of services is really important. There's a huge tension between trying to deliver those two for us. So not to just like flag it really.
Yeah, so I mean, I think I'd say that slide's attempting in 5 or 6 bullet points to condense feedback from a wide variety of different people. So you're absolutely right that some of these on the face of it may seem to contradict each other, but then
No, so I'm not. Yeah. I think they are both what people want, but they're quite difficult to deliver both into that thing. And then just the other thing, I was just wondering about the structure of this in terms of the children and young people, because you've got this start well, live well, age well thing. Why isn't the children and young people thing in the start well rather than being a separate strand?
Because within the local health and care plan, the start well priorities were children, was mental health, childhood obesity and risky behaviours. Other elements of work around children's services are not something that was picked out as a focus area for the local health and care plan. So that I think that's the one thing to say is the local health and care plan won't cover everything that we're doing. When we develop the document, that will reflect the rest of the work we're doing on A&E, planned care, children's services outside of these areas. It is a reasonable thing to say though, and it is a challenging narrative to tell when you're talking about how these documents fit together. We're working with the South West London Comms team around these deliberative events later in the autumn to make sure that's really clear. But in essence, for me, the local health and care plan is around things that are worth working on collaboratively with all partners, including the voluntary sector, and then there's obviously loads of other work we're also doing to good effect.
Yeah. James, did you want to say anything?
Yeah, I think that's right. I mean, I think that
generally.
so on that point, just I think the local health and care plan is going to, the challenge is going to be to sort of put all of the work that we're doing at multiple different levels in context. I think there will be some. It will have to function as both part of a South West London suite of documents that describe the whole, and also as a standalone local document. There might be slightly different cuts to do it, but I think it is worth, just even now as we're pulling it together, sort of flagging the inherent tensions within that process in terms of, there will need to be a cut of it that's very short and very summary for some audiences, and there'll need to be a cut of it that's very comprehensive and detailed for others, particularly when we start trying to turn it into actionable financial plans. So I think it will need to be, a set of schemes and initiatives and proposals and worked up plans that then are cut in different ways to work with different audiences. I think the other thing I'd say just about your comment about the inherent tensions is that when we have the deliberative event in November, this is not meant to be a event where we sit people around tables and talk to them about what we're doing. It's meant to be an event where we engage them in some of the trade-offs and tensions and some of the choices that decision makers have to make. So we need to actually bring those things out and say, okay, these are, you know, some of the issues that we face. There is a desire for continuity. There's also a desire for accessibility. The person who can provide you with continuity cannot be there all the time. So where are the things that are important for continuity to you, and where are the things that are important to accessibility? So we actually have the opportunity through that event to use the format to take people with us on that decision making.
Okay, so I haven't got much time left, but I'd really like to hear from some clinical colleagues. Mike, did you want to?
Yeah, I was going to speak, I suppose, as a locality leader, and just offer to Josh, as every year, our assistants in the localities to, first of all, to go out to member practices, to, you know, constituent members of the CCGs, to help to engage, and then later to socialise the more finished product. So each year, your staff have very kindly come out to our locality meetings and our patient groups actually as well, and help to solicit people's views.
So would this be in the October round of locality meetings?
Yes.
Is that still in time?
Yes, it would be. And also the other thing to remind us, we have the first of the joint clinical oversight group with Merton next week, and this is going to be the major item on that agenda as well. There's then going to be an ongoing programme of engagement within member practices, local professionals, and also the public.
Okay, cool. So quick, Sam and then Sarah.
Prevention, early intervention, and where that comes through. And there is a thread that runs through it, but it's not named as a kind of prevention. And there's something around being able to pull that out and tell the narrative about how we're engaging, not just with public health, but lots of other different initiatives.
Absolutely. In the there's a slightly fuller pack that focuses entirely on the health and care plan, that makes that a bit clearer. I think one of the things that we've done for the Merton plan, which we will look to do for the Wandsworth one after the transformation groups finishes, produce a bit of a clearer plan on a page that reflects the prevention framework we've already signed up to, running through it as well. But that's what.
And one final thing I remembered, social prescribing, sort of a bit unambitious in here. I wonder if we could think about really that is really what we're trying to do.
No, that's right. Thank you.
Sarah,
I was just going to be really quick and say I wouldn't want Wandsworth CCG to feel constrained by anything around their local health and care plans. I think that we can make it all encompassing. I think it's just about different audiences and how we reflect the different parts of the system. So I wouldn't want people to think we can only do it this way. I think there's a real opportunity there for Wandsworth to make this their own and ensure that it goes the right way.
Excellent. So thank you, Josh, and your team on a, albeit work in progress, but really, really good work. Thank you. I would encourage people to continue to just send points of feedback to you at this point. This is the point of time to influence this, really. So keep going with that. And we are asked to what?
Note for now.
We are noted. Thank you very much. Great. James, we're going to talk, your two items, which are both to be taken together, really, I think.
And apologies, I'm full of cold, so I'll try to get through without sneezing. I'll just do a quick introduction on both papers, and then perhaps ask Chris and Stephen just to comment. So we've talked for a while now about having audit and finance committees in common, and had a number of meetings with chairs. We took a paper through the last audit committee and had a finance chairs meeting in August, and these are the two papers that we're bringing for approval. And just to be clear on what we're trying to do and just achieve out of this, so in terms of the audit, we'd be looking to have alternative meetings between a local meeting and a system-wide committee in common. That would initially be across the alliance, but we would invite Croydon, and I think they will attend on that. And we'd be looking to have a rotating chair every meeting on that, so we'd have a good representation of that. We would look for the audit chair or a nominated deputy to come, and then it will be up to each CCG to decide how they nominate their own second attendee at that meeting. Excuse me. What we're not looking to do is hinder local accountability, or to sort of limit people having local sort of dialogue. What we're really looking to do is to share some experience, consolidate some of the work because things like primary care, it's a single team, so it's sensible to do it in one go across the 6 CCGs. Other things, it's sensible to do them all at the same time and have a report back that compares across the system. But just to be clear, everybody has their own audit plan, and everybody gets their own audit report as well. So there's a clear sort of still recognition around statutory responsibilities around that. And again, as I say, looking for shared experience. My experience of having sat through some of these meetings now, particularly when we had the finance chairs, when you get them all together, you've got a huge wealth of experience around that table, and that's something we need to make maximum use of for South West London. We're currently working up the terms of reference for both committees, and we'll get some legal advice on that, and we'll bring those back for ratification at next governing body, and we're looking to start from October on the audit committee. In terms of the finance committee, I'll just mention, it's broadly similar, but there are a couple of differences. It meets more often, but we'd still be looking to have a local meeting, then a system meeting, then a local meeting. There's a different sort of drive behind this, because clearly there are expectations in last year's planning guidance, and they'll come even stronger as we move forward around how we work as a system. We have system control totals. We have a number of areas where we work across the STP, where we want to have a system view of it, and there's a number of procurements that we have that go from a system point of view. So again, we'd be looking to do that, use that sort of facility to operate through that committee in common. Again, a slight difference there. We said we'd have a rotating chair, but the recommendation was we'd rotate it every 12 months, because clearly there's a bit more of a need with the financial situation to have some continuity. And actually, when we met last month, Bob Armitage has offered or volunteered to do the first stint at that. And the other difference there is that Croydon would be a part of this. Clearly, we can't separate them, so they've been part of this process from the start. And the other subtle difference is there was from finance chairs, a clear drive that we would look to get clinical involvement around the finance committee, because clearly we need that input and that expertise around some of those areas. The only final thing just to mention, which is a point that Stephen picked up, was really when you look at what the committees will do, they will obviously consider things together. They are committees in common, so they will make recommendations to individual boards. So in terms of the decision-making process, there may well be some things where we have decisions across the system, but they will come back through individual governing bodies where significant it's material and it's significant. I'll hand over to Chris and Stephen. Sorry.
Okay. Firstly, thanks.
Sorry. Hold on. I think two sort of general points I'd make, and then a couple of more detailed queries. Firstly, I do think this is really important. From the audit perspective, we've been concerned for quite a long time that there is a lot of stuff going on, sort of, I'll put it centrally as it were, across CCGs, which we worried about. Are they being subjected to proper normal audit oversight and challenge, as it were? So I very much welcome, this proposal. So that's good. The second general point is, when we discussed CICs about a year ago, or whenever it was we first started down this track, we did make a very important principles we adopted in general for CICs, which was that where matters were likely to be contentious or controversial, as far as practically possible, we would sort of bend over backwards to ensure that individual CCGs did have the opportunity to discuss them locally, as it were. And I think that principle should apply equally to both of these committees, like any other CIC. So I just wanted to reinforce that underlying principle, which is difficult to achieve in practice because it does create problems about timescale sometimes, and that's why it's important to stress. So those are my sort of particular points. There was a couple of very specific points, if I could. One on audit, one on finance. On audit, there was I raised this with James, and perhaps we can discuss it outside. But one of the key actions has a rather arcane thing about the signing off of annual reports and accounts. This was an issue that came up in the last cycle where Wandsworth board took a different view from other CCGs. We haven't discussed that again since that occasion. It's a perfectly reasonable question to ask, what should be the sign-off arrangements for annual reports and accounts, but I wouldn't want this paper to be taken as preempting a Wandsworth board decision on how it would want that to be addressed in future. So I just want to sort of note that.
That's absolutely fine, Steve.
The other particular question on the finance paper is on quoracy. If I read it correctly, on the finance, in the case of the audit committee in common, if the normal members for some reason or other couldn't attend, there is provision for substitutes. As far as I read it on the finance equivalent, there doesn't seem to be any provision for substitutes, and I just think that might be unrealistic in practice, because you can't guarantee that the normal members will always be available, particularly if it's meeting fairly frequently, so I think that ought to be addressed.
No, happy to accept that as an amendment to this report, so that's fine.
I concur with all of Stephen's points. I think it's quite important that the board agrees in some detail how this new method of working is going to evolve. At the moment, the constitution of each CCG sets out in detail the function and role and responsibility of its finance committees. So if we're going to operate in a federal system, which is effectively what this is, then I think the board needs to understand the implication of that, particularly, as James has stressed, this expectation that South West London resourcing is being managed as a collective enterprise. I think we just need to understand what collective enterprise means in this context. I'm not in any way seeking to inhibit this or frustrate it. I just think the board needs to be comfortable with how it's going to work.
Yeah, no, I think that's entirely right. I mean, we're moving into somewhat uncharted waters, so I think part of the way we manage that is having clear communication back, and we review how this is operating as we go on. And what we'll do after every meeting is we'll say, actually, are we getting the information we need? Do you feel, as a finance chair and me as a finance director, that we can go back to the board and give them the appropriate assurance and appropriate discussion? And we are, I mean, there's no hiding from it. When we get to the planning round, part of the reason for having this is it gives us a forum to have some what are going to be some tricky discussions. But I think it's easier to do that in a single forum than it will be to have it across different forums. So I agree entirely.
So agree on the operational management. What I would say is that as far as constitutional concerns, if there are any constitutional concerns, this is absolutely aligned with our constitutions. So there will be no change. The committees are still subcommittees of the governing body and are individual subcommittees. They do not work as a collective, as in they make a collective decision. They make individual decisions as committees together in the same room. And our constitution, with the changes that we made last year, allows us to set up committees in common for any of our subcommittees. So that allows us to do that through the constitution as well. So it doesn't actually change our constitution at all, and it meets the requirements of our constitution. So I think the issue is how we operationally manage it. I think that's really important, and that we do it in a fair and open way, and that the board is absolutely cited on that. But I wouldn't want anyone to be concerned that we are not doing what the constitution says we should do.
And in the proposal papers, it does talk about briefings for the board from each of those committees, which I think we just have to make sure that we get that right.
Absolutely. And one of the other things we've talked about with both of them is having the flow right. So when we move from a committee in common to a local, we know what the actions are, we know what the key issues are as we move through. So there's quite a lot of work going on. It's getting the paperwork and that process right.
Yes. Carol.
Just a quick point. Thank you for the clarification, Sarah. Earlier in this discussion, mention made of discussing locally, and I noted down, is it about discussing locally or deciding locally? Because this is not a decision-making body. The decisions will be taken at local level.
So it is the Finance Committee and the Audit Committee. It's just that they're meeting together so it works in exactly the same way as it does now. It's just that they're meeting together. So any decisions that they would make now, they would continue to make. They're not making any different decisions to the ones that they were making previously. I wouldn't want to say they're not making any decisions because the Audit Committee and the Finance Committee do make decisions, but they will continue to make the same decisions that they've always done, and the governing bodies will continue to make the same decisions as they've always done. So if there were anything that would come to the governing body normally, that will continue to come to every single governing body.
Stephen?
There is a point which I hadn't thought of, which is that we need to look at the quoracy, and that's quite right. These are meetings of these committees.
Yes.
But I haven't gone back to the quoracy of our existing committees because there are only two people there. They might not be quorate under our current terms of reference. So I think we need to revisit that and think about how we handle that if that's true, which I think it might be.
Okay, I think that's helpful. We'll go back and check.
Yeah, okay. Thank you. Okay, any further comments or questions on this? So we're asked to consider and ratify, so I think what I'm hearing is that we can do that, but subject to the queries that came from Stephen, and that check now on the quoracy, which I think might be quite important to address. Carol?
And review as it goes along to see how it's working.
Yeah. Okay, so the only final thing I want to say is, so just in terms of sorting out this issue about sign-off of the accounts, can we schedule a board discussion on that then? I think that would be helpful to do. Thank you. Excellent. James, thank you for all your work on that. So that we have considered and ratified. Thank you. Okay, so now we're on to mental health. So Dr. Coffey has arrived. Tom Coffey is our clinical lead for mental health, and Mark Robertson is the commissioning manager on this. So, chaps, do you want to move in a bit? So, are you going to use a presentation?
I think so.
Where do you want to sit then, so we can? You don't have to stand up. You can take the mic off. Oh, yeah, good idea.
Tom's coming and taking over.
Yeah.
I was trying to keep in record, I said nobody was too close.
So this is one of our clinical spotlight areas. So most meetings we try to make sure that we're talking about a service or a clinical area to make sure that the board is really sighted on what's going on at ground level, and maybe being able to link that to the discussions we have at board and the strategies that we're setting as a CCG. So it's really important that we stay connected with that. So Tom and Mark, thank you for coming. Do you want to just kick off and go for it?
Okay. Presentation, and as ever, really, my thanks probably goes to Mark Robinson and Bisaya, who are the commissioning team who support the work that we do and do it fantastically. What I'd like to do is really just to describe very much our approach to how we try to care for our patients with mental health problems and prevent mental health issues in Wandsworth. Talk very much then about what we're doing and also the new work we're doing. But what I'd like to start, I suppose, first is a thank you to the board, because as a board over the last number of years, you've given a very clear commitment to mental health services in Wandsworth, and it's a shame Neil's just walked out the room, because I was going to do a big thank you to Neil, and you've backed up that commitment with the money that you promised. So we're one of the CCGs which have hit our mental health investment standard every single year for the last 5 years, and that not only gives the benefit of the services to our patients, but it also means that we can hold our head up high when we talk about palliative esteem and we're doing what we say we would do. Also, it does have the added benefit, which I think Sarah is aware of, that when the NHS decides now how to invest
in CCGs, it uses that commitment and measures it to make sure you've done it. So when we were chosen to be one of the trailblazers for the new schools-based health service, one of the key criteria was, did we hit our mental health investment standard? The answer was we did. Neil, you in fact, as a Man City fan, I'm glad you're out of the room. I give a special thank you to you and your team for the support you've given to mental health over the last few years.
So rarely.
It does, yeah. Very rare. And so, and also just to kind of understand how we do mental health generally. So just a few stats. So what we've got to make sure is that the 5-year forward view gives us a clear direction of travel of how we should be performing. They measure our performance quite rightly, and often mental health didn't have the same focus. So we're meant to make sure patients referred to the CMHT are seen within 28 days. 81% is our standard. Last month we did 96%. Patients who need to be seen urgently should be seen within 7 days. The standard is 90%. Our last month performance was 100%. Patients who've got a new psychosis, half of those patients must be seen within 14 days. And again, we hit that target. We had 4 patients, we saw 2 of them, bang on. All right? Small numbers I accept, but we are hitting that target. So therefore, I feel that the investment that the board and Neil has guided is delivering the performance we said it would deliver. Also, to understand our community, right? Wandsworth, is an area of high mental health. We have the highest incidence of mental health, in South West London. We also, have a very large population. We've got 25% of our population are from the black and minority ethnic community, but 40% of users of our service are from that group. So therefore we have agreed to have a dedicated work stream in this area, which I will try to highlight later. Also, our work on older people and dementia. So our pickup of patients with dementia has increased enormously over the last few years, from 35% now to 72%. So that initial thrust of trying to identify patients with dementia has worked. And of course we're now moving on to the next work stream of how do we make sure after diagnosis we offer the care that those patients need. Our finances, we are probably the biggest investor in our local mental health trust in Wandsworth. And also our mental health investment standard that I kind of look at very carefully with Neil and Agnisha and the team, and we make sure it is spent wisely. And we do hold money back, as because we need to ensure that unforeseen circumstances are addressed financially, and we've got the money to do that. And that's the approach we always take. But we also make sure we use our money where we can have identified need. In your paper, you look at a demand and capacity analysis, and the area which is red is our CMHTs. We looked at that, and in fact we're using the mental health investment money for this year. We've invested an extra £358,000 in that area, because we recognise, not just from that demand and capacity analysis, but also from the feedback we're getting from our GPs, from our patients, that service was under pressure. And since we've done that, the Make a Difference alerts, the performance that I've just indicated to you has improved remarkably. That demonstrating targeted investment in areas where there's evidential reduction in capacity has benefits. What I'm going to try to do is also look at just the groups of patients that we care for. So we've got the older adults, and I've identified the work that has been done in the identification. What I've also noticed is that the number of patients, especially from care homes with dementia, were being admitted to hospital for both medical and mental health issues, but often for medical issues. And in fact, if you could address their mental health issues and their issues regarding behaviour and communication, you have a massive benefit for them to stay in their homes or their nursing homes and reduce admissions to hospital. And the behaviour and communication services started initially just at nursing homes and now going into the community and having a distinct effect on admissions to hospital and well-being for those patients. For working age adults, what we've focused on for the last few years has been making sure our CMHTs and our single point of access works effectively, and I think I've indicated that earlier. Also, what we've tried to work out is how do we support primary care? And the project you're seeing up there is Primary Care Plus. This started in the Wandle area, whereby practices are offered a worker who will do one of four things. They will see all patients discharged from a CMHT within 2 weeks. They will see all patients who are on your mental health register every year. They will see all patients who are on a depot every 3 months, and they will take referrals from general practice for patients they're concerned about but will not meet the threshold for a CMHT. That's been rolled out in the Wandle, and now it's being rolled out, and we're just recruiting at the moment for West Wandsworth and for Battersea. And I visited both forums to ask who's interested in taking one of these workers. Every single practice put their hand up. We're getting universal coverage throughout Wandsworth. That service costs £488,000. That's where your money is going. And we feel that is having a massive benefit for those patients who've got severe injury, mental illness, are not under a CMHT, and are not being lost in primary care. Talking therapies, IAPT is a service which we have invested in as well, not only because we've re-procured a service, but the target of the number of patients needing to be seen is increasing every year. The target this year is 19% of our patients with a common mental illness. That figure is 44,000, so we've got to make sure 19% of those patients receive that service. I feel in the last 12 months that service has improved quite remarkably. There's been new leadership in the service. John Atherton has had a key role in making sure the performance of that whole team has turned around remarkably. The recovery rate is improving, the access rate is improving, the waiting times are improving. Yeah, I do have a concern about the waiting times and how we report it. That they are reporting it according to guidelines. However, if I was a patient, the gap between the first and second appointment is too long. We're saying to patients, you're starting treatment in 6 weeks. The patient doesn't really feel they've started treatment until their second treatment and the 10 thereafter. The gap often is 10 or 12 weeks between the first and second treatment. That we're going to have to address to make sure that the genuine waiting times is what the patient sees and feels. But we are doing that and making sure the capacity is there to do that. The work we're doing with St George's, which has over the last 12 months, is making sure they've got a good psychiatric decision unit. And again, the funding this year from the Mental Health Investment Standard has gone to pick up the funding for that, and the crisis cafes, and the street triage. Also, we're very fortunate to have been a recipient of the South West London perinatal mental health bid. So we are, I think, phase 2. And the money has been announced for South West London services. As it happens, St George's, Wandsworth has quite a good service anyway. So the amount of money put into Wandsworth is probably less for other local boroughs, because we're starting from a higher starting point. You'll have seen something there called Active Wellbeing. This is one of our favourite little projects. Little leaflet here. So this is a project, we had a meeting yesterday, and I thought I'd share some of their information. This is a project saying, how do we work with patients with severe injury mental illness who die early, not because of their psychiatric illness, because of their associated cardiovascular, diabetes and respiratory morbidity or mortality. So this is a project whereby we spotted a gap in the market. If you're a personal trainer, most of your clients are working, and therefore they want to see you between 7 in the morning and 9 in the morning, or 6 in the evening and 9 at night. So you're twiddling your thumbs in the daytime. We've got a group of patients with severe injury and mental illness, mainly schizophrenics, who don't tend to go to the gym. Their lifestyles don't lend them to pop into the gym or to the exercise class. So we've brought the two together. So we've got personal trainers who are now working one-to-one with patients with schizophrenia. They're offered 12 sessions, and the outcomes are quite impressive. You won't see this graph very much, but this is their outcomes of their mental health and their blood pressure and their weights. So, it is having a distinct effect on their mental health well-being and their physical well-being. And I chatted to the guy who runs it, we fund it, and he says he has, personal trainers queuing up to be part of his service. because for them it develops into a new way of working. So that I think is quite impressive. My next slide, that way. Again, new children, young people. So we already have, I think, quite a good CAM service in Wandsworth, but the School Trailblazer project is going to make it so much better. This is a project, and because we've hit our standard, we've been chosen to do it, our finance standard, whereby the government is going to invest millions into this service. It's going to probably try and do three things. It's going to have the approach to say children at school have poor access to mental health services. So it will mean that every single school in Wandsworth, primary and secondary, state and independent, will have a mental health worker. Every single school will have a teacher. Most people are aware of what's called a SENCO, a Special Education Needs Coordinator. There'll be a similar one now for mental health in the schools. Also, every single school will have a linked CAMS worker. The plan is to increase the number of children going into these services every year up to 500 per 8,000 children. We have 38,000 children in school in Wandsworth, so that is probably an extra, that will mean 2,500 children every year will be availing themselves of this service. So we're putting in our bid, and fingers crossed the bid's going to be successful, and I think that will have a massive impact on our children in Wandsworth, especially because if you look at the most recent national data on common mental illnesses, young people, not just in Wandsworth but the whole of the country, are having an escalation of mental illness, especially young women, and especially self-harm, anxiety and depression. And this project will particularly focus on that group. I've mentioned already the other new projects for South West London, so the South West London Perinatal Service, the Children and Young People's Plan, and also what we're trying to do is that thing about how do we make sure we integrate physical and mental health, and I gave you a little picture of our Active Wellbeing project. So I hope that gives you a flavour of the work that we're doing, that we are very grateful for the board support, the financial support, and hopefully we're delivering both on the performance and changing how patients cope and live with mental health in Wandsworth. Thank you.
Thank you very much, Tom. Excellent. That was really, really good to hear an update on that. I'm sure people will have questions and things they want to say. Carol, do you want to start?
I'd just like to say thank you, and I think the service is good and has been improving over time, and I think the school's Trailblazer project is fantastic, and I do hope we get the money. I mean, it is such a good initiative. I think it's really excellent, so thank you very much.
Excellent. Sarah?
So children and young people mental health has been identified as a priority for South West London through the STP process, and there's been a huge amount of work going on locally across, not just in Wandsworth but across South West London, and also looking at self-harm, which has been a significant issue in South West London. I'm really hopeful that we will be successful in South West London. This is a Wave 1 bid that we've been invited to bid for because of our delivery in 3 boroughs. I would like to then put that across the rest of South West London as well, because I don't think it should be just in 3 boroughs, it should be in all 6 boroughs in South West London. So I'm really hopeful that we will be successful because we have prioritised this, because we are doing the work as Tom described, and I think we should all be lobbying for that. So I'm asking everyone to lobby for that.
Great, thank you. Roo?
Yeah, thanks Tom. Just a quick question about referral and assessment to the CMHT. About a couple of years ago, I think to the members' forum, there was discussion about how patients might be able to self-refer, which naturally created a lot of sort of debate. And I could sort of see the value of it if they had the right structures behind it. I just wonder whether that's still being considered.
Yep. So initially what we wanted to make sure was that other professionals can be very aware of the ability to refer to the single point of access. That means the police, teachers, local authority housing workers, so they now often will refer directly to the single point of access. Secondly, when patients are discharged from the CMHT, we say to them and their carers, if you deteriorate, go back to your GP, but if you can't get your brother, your sister, your family member there, you can directly refer to the single point of access. Also, members of the public can self-refer to the single point of access. They will go through a telephone triage. If it isn't appropriate, they'll be passed on either to drug and alcohol service, to IAPS, or they'll be seen. And in fact, by having done that, there isn't this massive flood, oh my gosh, we're going to be overwhelmed, because most of the patients who've got a significant and severe mental illness will go there either self-refer or go maybe a week later via the GP, or tragically 3 weeks later via A&E. It's better to be referred early when you're having a crisis in your mental health.
I've got Mike, then Chris. Mike.
So I'd like to give, I suppose, a viewpoint as a practicing GP and also as a locality lead. I just want to say, first of all, thank you very much to Tom, to Mark, and to the team behind you that have made a significant difference at a time when in many other areas it often feels as if we're really struggling to get patients seen in the place they need to when they need to be seen. There's been a marked improvement in our access to mental health services, partly because of the single point of access now working quite well, but particularly I want to say that the difference that the Primary Care Plus programme has made to us. So this is the programme that Tom referred to, where we have in primary care now mental health workers working in our estate with us, able to see our patients. The difference it's made to my patients and to my practice have been that patients who are some patients are very reluctant to go to a secondary care estate or to see what they perceive as being a stigmatising service, can actually receive really good care and good advice in our estate. So patients are used to coming to general practice to the GP surgery when they feel physically unwell. It's great that then they can now also come to us and receive some specialist care when they feel mentally or psychologically unwell. Second group of people, I think, who feel quite abandoned sometimes when they are discharged from the CMHT. For all other areas of medicine, you'd probably see it as a great thing. So the heart doctor says, "You're fine, I don't need to see you anymore." It's brilliant. But for some of our mental health patients, they can become quite dependent on secondary services, and it can be very difficult for them being discharged. Our worker, a chap called Kurt, is amazing. He works with me on a Friday, and I've seen the difference it makes to my patients. So I just want to say thank you. It makes a real difference on the ground.
Great, thank you, Mike. Stephen in a minute. Chris.
Do you know, it's a real joy when you come in and make a presentation. Every time you have presented to this board on whatever topic it is, you have succinctly and effectively communicated A, the problem, B, what needs to be done, and C, the progress that's being made. Now that is a case study in how to present information to an organisation like this. In my part of the world, in the West Country, mental health is a disaster zone. Night after night after night, we have examples, often of young people, often young women self-harming, often committing suicide because of the absence of good quality mental health care. Here we have a good news story. Well done.
Thank you.
Thank you. Stephen.
Difficult to follow that one. I just wanted to ask, I don't have a picture in my mind, and maybe a question for you or for Neil, I don't know, of the total spending, which, as you say, has been protected and increasing. What sort of ratios is it in broad terms between, quote, secondary, if that's the right term in this world, and community
I'll start
spending?
And Neil might finish. So therefore, I think the budget for mental health is 52 million. Ish, and then how the mental health investment standard works is the growth that the CCG gets is given to mental health and protected. And so, as a proportion of the wider budget, you mean the mental health compared to non-mental health services?
No, I mean the proportion within the mental health world, the balance between what we're spending on the mental health trust versus the community, and is that balance shifting over time? Are we moving money into the community disproportionately faster?
So I think to answer that, you're broadly looking at around about 40 million is with the trust, and therefore the 13 million outside of the trust. We are making investments in community services via the trust, so that is part of the investment, but of course there is a challenge there because they're not necessarily seeing the switch from inpatients, or that's the dilemma that we've got, but that's where the investment is happening. So to say 40 million, I guess what you probably want to understand is the breakdown of the 40 million, which I haven't got in my head.
The story I'm groping for is switching more money into the community.
As an example, let's say the 1.5 million that we had this year, I would say it's 50-50. So therefore, I'm not, because Josh might easily give me a steer here. So normally, let's say 80-20 is the residual spend. The new spend is usually about 50, 60%. I think the proportion that is going into the community from the mental health investment standard is greater than the proportion, presently at the moment. I mean, Josh is the person who's probably got the greater overview of this than I have.
Yeah, that's in essence the summary. We do need to continue investing in improving the secondary care services in mental health, but I think we see more of our growth monies going into community development, which in turn helps performance and quality in the secondary care space as well.
Sarah? Just strategically, I think it is absolutely the case that what we're looking at doing is supporting people in a different way through mental health services. We're looking across South London at those with very severe mental illness, where we're actually making placements outside of South London, trying to bring those back in. So there's a South London partnership now of mental health trusts, and they're making efficiencies by bringing people back locally, which is where they need to be treated, and supporting them in a different way, and also making efficiencies, and that money is then being reinvested locally into the acute services, and we're also doing investment then into the community, and it is about changing that whole model of care. And if we look at the forward trajectory for South West London St George's Mental Health Trust and the new beds and how that will work around the site that we have at Springfield, we will have the right number of beds but the right community services around it to be able to support people in a different way. So I think that is the strategic direction. I think in the meantime we still have to invest in both community and acute in order to get us to the right place.
And the difference, you'd probably say, if you're comparing us to other CCGs, the difference probably is that we're a key investor in our South West London St George's, whilst other CCGs tend to invest in other secondary care services and have sometimes disinvested from the mental health trust. So therefore our IAP provider is South London St George's, our primary care plus provider is South London St George's, whilst some of the other CCGs have tended to go to other mental health trusts to get their support. Because of the benefit of integration and reducing handoffs between services, we've tended to see can we use the local mental health trusts, because patients tend to move through the service rather than stay in one little service.
Okay. Tom, last thing from me, I think. So, two questions. One is about the black and minority ethnic groups, which you alluded to. So I think we all recognise that access is really important and a culturally sensitive service for this. So is there more that we should be doing on this?
So as it happens, so we have a subgroup looking at this particularly, and we divided it up into 5 areas. It's the early work, prevention work, early intervention work, inpatient work, and a readmission prevention work. And so we are investing in quite novel ways in all 5 areas. I mean, to be honest, if Malik Gul here is a great champion in this area, I think he would like perhaps more investment in the early intervention stuff and trying to place more services within the community. So what we do at the moment, we have got a training program for imams and pastors from black majority churches who are doing a 2-year course. So they are trained in to identify and to give initial treatment and to refer on for patients within their community. Everything that, in fact, I have to say that we've been asked to do, we've funded. I don't think there's any project that has come through that group which has got evidence behind it that we've declined. I think there is the wider societal issue, which is very hard to address just with health. And I guess, working with the local authorities, I think you might have a bigger impact, but there isn't any magic bullet at the moment which I think, we haven't done that because we haven't got the funding or the resources.
Okay.
I actually think we have done.
Yeah. Okay.
Mark, is any?
No, I think you're right. I mean, I think the thing that you say is about embedding, and it goes a little bit back to the question about how people not so much self-refer, but how so work that Malik, the pastors network that Tom alluded to, one of the big pieces of work they're doing is about how they can assess, how they can do assessments which are then accepted by the secondary care, so how they can be more embedded, or it's not so much them being embedded in secondary care, it's the other way round, because it's actually to be embedded in secondary care puts up the barriers which the whole the service is trying to avoid. So I think, but that is something that we are working on. We have invested in that. We invested in the community champions. A lot of this is quite longitudinal.
Yeah, I think it's going to take a generation. 20 years. Yeah, I'll still be here.
I know. And then the other thing I want to talk about is dementia, because this is just a growing problem, and we've got, and I know that there's been a lot of work to identify these people, plus there are increasing number of cases anyway, and we've got issues with social services funding, which means that sometimes these patients are struggling in lots of ways, and their carers and families particularly have an enormous burden. So the work that's going on with the BCS team, etc. So I think that's all good, but I'm just thinking ramping up capacity in this is really, really important. And remember, in the old days we had the older people's health visitor, and I'm just thinking of some kind of hybrid between that and the primary care plus for dementia, because not everyone will need the BCS team, and maybe there's something else to be done in terms of ramping up capacity in primary care.
So we can definitely consider that. I'll say as a caveat, so I'm not the clinical lead for dementia, but the mental health investment standard can be used. I'm looking at Neil here for dementia services. So Alison Kirby. So who would be should we take that forward?
Just to add to that, so in the previous item on Wandsworth Health and Care Plan, one of the areas of focus is mental health and physical health integration, and I think another one is also dementia. So I think there is an opportunity in the next round to bring some of that together.
And the piece of it was something which you suggested 2 or 3 years ago. Oh, why can't we have a psychiatric nurse within each practice? And we did a PCP because, in fact, the people who are the mental health practitioners are probably more appropriate than the CPNs. So we could do a similar one for dementia, but and we might have to look at the money for next year and a project, and we'll take a steer from Josh on that, to be honest.
Yeah, good. Okay, thank you very much. So we're just asked to note the report. We've done more than that, and we've overrun. I'm sorry, but I think really for really good reason. So Tom and Mark, thank you very much. And so Tom, you thanked the board for the kind of level of support that you've had, but actually it's because you have motivated us to do so. So thank you for your input and your passion over the years for improving people's care with mental health problems. Thank you, and thank you both for coming. Now we're up against it, aren't we, folks? Okay, so executive report. James, what did you want?
In the interest of time, and given we've covered a number of the items on other areas, I'll take it as read and take any questions.
Yeah. Okay. Anything? Thank you. Thank you for that. John, performance report.
I think likewise I'll take it as read and happy to take any specific questions, and just a few areas to directly update the board to call out some of the detail. The A&E performance at St George's started the year very well. The trajectory that was agreed wasn't to achieve the 95% standard throughout the year. There was a ramping up over the first few months, and April and May achieved or exceeded the trajectory as it was set out. More recently, in June, the latest position, 93.59 against the 95% standard, and that's carried forward to July with a very similar performance at 93.28. So performance is very much stable, and has for the last 3 months been around the 93% mark. So clearly a very different position from this time last year, where performance was several percentage points below that in the high 80s. And we continue to work very closely with St George's around the delivery of the A&E standard. So there's particular work at the moment looking at the differential impact of various shifts working at St George's and what that shift leadership is doing. We've seen variances of around 8 or 9% over a single week, where attendance has been relatively stable over that period. So the Trust are doing a lot of work around workforce, both in terms of recruitment and filling some of those junior vacancies they've got, making sure the locum fill is what they require, but also looking at the variances of each shift as the week plays through. They continue to implement their 15-point improvement plan. and we're waiting for a more detailed update of overall delivery of that plan. Yesterday we had the first of our detailed winter planning meetings with the Trust, where they set out and we work to mitigate the perceived demand and capacity imbalances that they might have over the course of the winter, and with all system partners, so working with primary care, local authorities, community providers, to look at again the differential impact of projecting what gaps may be, and also in terms of workforce, because I think last year we had the detailed update from Sean Stoneham a few months ago, but I think sometimes where we'd planned to have capacity, we weren't necessarily able to fill that with workforce. And I think finally we're looking again at the pressure surge model. We agree going into winter a whole formal range of mechanisms around that, and I think we're looking now at making sure that all those escalation issues in and out of hours at CCG level, at acute provider level, at local authority level, are all absolutely at the best place they can be going into winter. And I think, in NHS definitions, I think winter probably now begins around November time and continues to April sometime. So we're looking at best part of half the year in terms of increased surge. So having just finished a heat wave, we are in earnest looking at what the winter might hold. Just two more brief updates then. So the RTT position, we are working very closely with St George's now as they look to recommence national reporting at some point in this financial year. NHS England, NHS Improvement have a whole series of guidance on what provider trusts need to do if they want to recommence reporting after a gap, and that sets a very high bar in terms of the data validation, the ability to have a sustainable, accurate position, and expectations around a third-party review of the situation, and completeness around all the ways in which waiting times are tracked, so through the usual patient tracking lists, etc. So we're working around what the governance might be for that, and finalising what the commissioner assurance will be, because although it is the Trust's decision to recommence reporting, there is an expectation, a very strong expectation, that comes with assurance and agreement from the lead commissioner. Finally, cancer, you'll note from the report there's been some performance issues in recent months with cancer 2 weeks waits, particularly the breast symptomatic 2 week wait. We've discussed this at length with the Trust. There was something of a perfect storm around capacity for this service, with staff members leaving, with high sickness rate, with retirement, and with unavailability of some regular locums. The more recent position, which isn't in the report, because we got some provisional data for August and some confirmed data for July, shows that the position has now been fully addressed. From the first week of August, the system is back in recurrent balance. So the 2 week wait breast symptomatic position for August is likely to be, that this isn't yet confirmed, but likely to be mid 80%. And then from September onwards, we'll be back at 93% standard. And in July, the 2 week wait recovered back to over 93%, and again provisional August data shows us that again it's highly likely to be above 93% in August. So I'll pause there and happy to take any questions.
Can I press you a bit more on the RTT position? This is quite it's a quite uninformative paragraph. I don't get a sense of progress. I get a sense of a work stream, and you said, in referring to it, you said they hope to come back on stream in reporting sometime in this financial year. Do they have a plan? And if so, when are they hoping to come back to reporting?
So there is indeed a plan to come back onto reporting. The Trust have been very keen to work to a December date for reporting. So we're looking at the remaining validations that they're doing to make sure that all that residual backlog validation where people had uncertain outcomes from appointments is fully complete. It's likely that the period of time when they recommence reporting will be somewhere between December 18 and March 19. I think that's, I'm looking to James, but I think that's probably the most realistic window that we're looking at the moment.
Yeah, I mean, so it's a fair challenge, Chris, because what we've been working through just this week, actually, with John and I met with the St George's Chief Operating Officer to go through in detail the assurance process that we would put in place around return to reporting. We will be commissioning an external assurance review in order to go through the data quality systems and processes and the accuracy and sustainability of the waiting list system at St George's, and the scope of that work will be agreed through IGQC. We're planning to do that in October, and it will report back to this board as well as the lead commissioner. So I think that we are anticipating undertaking that work through Q3, and it will be on the basis of St George's being able to demonstrate sustainable data quality standards for at least 3 months, to be able to come through that review, for us to consider that review, and then both ourselves and the trust board will need to make a decision that it's right for them to return to reporting. So I think we are actually, in the context of almost 2 years off reporting, getting into potentially the phase where they will come back. But I think that what we are all keen to do is to be absolutely clear that we will be led by whether it is the right thing for them to do and whether they can demonstrate that they have the appropriate data quality and the sustainability of systems and processes, actually, which has always been the challenge in order to do that.
Thank you.
John, thank you very much for that.
Thank you.
Finance report, Neil.
Okay, so I'll try and be brief as well. So this is the month 4 report. I'll just give you some of the key headlines really from that. So you'll note in the finance scorecard under the governance section that we had to complete a finance and governance checklist. This is a new requirement this year, and one that we have to do quarterly and have to do an annual review as well. The audit committee did review prior to submission and they were content with that report, but there are a number of actions that will come out of that we will need to work our way through. Moving on to the overall position, you'll know that we're year to date and forecast outturn, we're actually on plan. However, there are a number of emerging risks which hopefully you'll have picked out through the report. Just taking each of the areas individually, so around the acute position, it is still an early time of the year, so it is only based on month 3 data, but we are already starting to see pressures, cost pressures emerging around Guy's, Kingston and St George's. The St George's one, we are making the assumption that the QIP will largely mitigate that because of the schemes that we've got, which are to kick in from the second quarter onwards, so we're going to have to keep a very close eye on that particular area. The CSU are pursuing a number of challenges with particularly St George's, but there is some odd areas around Guy's, and given our relationship with South London, we're looking for that team to take forward to understand a bit more about what's going on around Guy's as well. In terms of non-acute, and actually at least my report corresponds with what Tom was saying. So around mental health, we still have some funding left for commitment. We do this every year just really to be prudent in case other areas crop up that we may wish to invest in, but if some of the cost and volume contracts overheat, we've at least got some mitigation against that rather than committing everything up front. But the money is there and available should it be needed. The one area that I think we're seeing big pressures on, as we've seen each year, is around the any qualified providers, particularly around the MSK and podiatry and diagnostic services. So I think we need a bit of a closer scrutiny to ensure that some of the QIP schemes that we've got to address that are going to actually address it before the end of the year. In terms of primary care, We've got some issues around the delegated part of primary care. This is mainly due to contractual commitments, and that's linked really for the Agenda for Change pay award that's gone through the practices. That's built into the position, but at the moment we have no further mitigation or no budget in there, so that's showing us an overspend around that. In terms of prescribing, again, only 2 months worth of data, just to note that the first 2 months of this year are actually higher than they were last year. That does present me with some concerns, but at this point in time we're showing that it's on plan. We are aware of a price increase for category M drugs coming through in August. At the moment there's only a commitment for a couple of months of the year, and they will then review where we are. So there's hopefully we will have some further mitigation around that category M price increase. In terms of QIP, the assumption is that there'll be against the original plan, we think around about a £1.5 million shortfall. At the moment we believe we can cover that from budget underspends and other non-recurrent commitments, other non-recurrent means, so things like unutilised accruals. But as I mentioned earlier, that is predicated on the fact that St George's and the QIP schemes associated with that start to deliver as well. Running costs all on track, and in terms of the financial analysis, the only bit I would like you to point out is around the aged debtor, and in particular the issue around the prescribing recharges, which we have picked up since we took on the commissioning responsibility for the Royal Hospital for Neurodisability. So we are having some difficulties collecting that debt in, and we're probably going to need some assistance across London. So I've been having conversations with James about how we take that one forward. All the other indicators in there look to be okay. So I'm happy to take any further questions that anybody's got on the report. Thank you.
Sorry about that. So you know on your scorecard, under financial risk, for as long as I can remember, you've had this one which is about the ledger system, which we were flagging as. Now, are you telling me that that's been fixed and isn't a risk anymore? It's just that we've got so used to dealing with it.
Yes, I think on the basis that we've lived with it for so long that actually it can't really still be a risk, because it would have nothing has
more
happened.
More of a pain than a risk.
It is, absolutely, yeah.
Fair enough. Yeah.
Well spotted.
Yeah, thank you. Jolly good. So, yeah.
I still do feel we ought to, I mean, it pains me to say so, because I've been arguing this. Now we have James in place, I think I'd like to suggest that James might pursue this. We've never had a substantive reply from NHS England as to either they cannot fix it or that they are not doing it for some good reason. It's just been left in a complete limbo, and I do think it's unacceptable, actually. Yeah. And I think it's fair enough to take it off our risk list, if you like, but actually it just is ridiculous that this issue is just left hanging and we can't get them to give us a substantive reply. They're either not going to do it, they can't do it, or they won't do it for some good reason.
Yeah. There you go, James. Can you go on your ridiculous list, please? Thank you.
Thank you, Stephen.
Thank you. Good. Okay. Neil, thank you for that. So, Health and Care Partnership update. Sarah.
I'll try and be brief. I would like to just say a couple of, so this is the report that we promised to bring, which is going to be a regular report from South West London. Please do give us any feedback if you want any other changes to report. I would like to just say some welcomes and thank yous to a couple of people from this report, and then leave the rest as read. But welcome to Cheryl Coppell, OBE, who will join us in the next couple of weeks as the independent chair of the Health and Care Partnership, and you can read all about Cheryl there. And a thank you to Dr. Andy Mitchell, who has covered for the last 12 months for us as independent chair, and all of the work that he's done, and particularly around the work with the Clinical Senate. The quartet, which is the 4 leads across South West London, so myself, Dr. Naz Giovanni as the clinical chair rep, Jed Curran as the local authority rep, and was John Goulston, who was Croydon Health, is retiring at the end of September as provider lead. We will now be having Anne Radmore, who's the Chief Executive of Kingston Hospital, as the provider lead going forwards. So thank you again to John, and welcome to Anne as the representative on the quartet for South West London. Everything else I'm going to assume that you have read, and I'm happy to take any questions on.
Firstly, because I've been pressing for this, very warm welcome. Thank you very much indeed, Sarah. That's really helpful. But it would be really useful to have something not on this scale, more equivalent to James's report perhaps, on the Alliance. Because I suddenly realised when I got to the end of it, what I wasn't getting was, the things going on at the Alliance level. This is very much STP, which is absolutely right and fair. So I think there's still a slight question mark in my mind about the transparency of what's happening on the Alliance thing. But I don't think it needs something of this sort of quality or professionalism or length. It needs something more analogous to James's executive report.
So I'm happy to have a discussion outside about what that might look like. I mean, the Alliance is the CCGs. There isn't something called the Alliance that's separate from the CCG. So everything that you receive at CCG level is the Alliance. There's not something. I mean, the only things that the Alliance are is a couple of posts, to be honest, which is kind of myself and James, and where we shared across. So perhaps I can understand what it is that you're looking for and in what areas, because you receive everything that is Alliance level already through the governing body. So
and it is worth saying that we do put bits of Alliance business into my exec report, so that, for example, the item on 111 out of hours in my exec report is something that's gone in all 5 governing bodies MD's reports, because we need, we think we're bringing business probably through that channel at the moment, Stephen.
So I think it's the business as usual that is the 5 CCGs, but if there's something we feel we are missing, then I'm happy to look at that and try and work out what it is.
I suppose it's the not knowing what you're missing to say.
Yes.
Yeah.
And I'm not sure what it is
I'm not
either.
sure there is anything.
I'm not sure there is anything, no.
Well, as an example, we have later in the paper, I think, something about a CIC coming up.
Yes.
And there's quite a big agenda there. And that whole agenda, I mean, I do see it because it is in our paper, so
Yes,
in that sense. But it was all news to me, and I thought, gosh, clearly something's been going on, and I don't know what I don't know is the truth of the matter. But
So we need to put that right, because actually most of those items I think probably governing bodies do know about, so we need to think about if are we doing that in the right way. But yes, absolutely. But they are coming through governing bodies, that's the whole point, yeah.
Yes.
Okay. Right, so we'll further work outside of this meeting to try and understand that then. Thank you. Yeah, thank you for that. So on to Audit Committee Annual Report. Stephen?
Well, do you want me to? I'll introduce it. I mean, to be honest, it's a fairly straightforward item. This is a report. It's a requirement that has to come to the board on the workings of the Audit Committee over the last 12 months. So the report just takes you through what the remit of the committee was and how it provides assurance to the board, and what the committee has been looking at over the last 12 months. I think it's probably fair to say no significant issues have emerged, and in terms of 17-18, and then finally there's a look ahead to how we will operate in 18-19, which picks up some of the points that James mentioned earlier, and what some of the areas of focus are likely to be. So I don't know whether Stephen wants to add anything more to that.
Not particularly. My iPad has decided not to show these later pages, so. But it's basically just a report. There's nothing the fundamental point is I think things have gone reasonably well.
Yes. Thank you very much. Okay, did anyone have any questions on that? Good. Thank you. Right, then I think we're on the last bit of the last leg really. Board assurance framework. So normally Julie would present this, but Fraser, do you just want to flag any issues?
Yeah, just very quickly. I mean, this is coming to you. It comes twice a year, so this is the latest version. There has been some development with it, and those of you that are involved with the Integrated Governance Committee will be aware of some of the changes and things that have been happening with the risk management system over the last few months. just to provide some clarity for people, the basis of this is that it allows us to assess how things are going in terms of achieving our corporate objectives. It uses principal risks as the basis for us assessing that, and the primary focus then being around sort of what controls we have in place and what assurances we're then receiving against those controls as to how we're assessing that. One other thing to state then is that primary principal risks are defined as those that have an inherent risk score of 15 or above. 15 being the point where on the 5x5 matrix where risks are classified as high. So effectively we're talking about the red risks. Inherent being the point before we consider any mitigating controls we have in place. So that is the basis for why how the risks get brought into the board assurance framework. Just a couple of things just to stay on the structure changes that I've made. The first couple of pages just list the risks that are included in the BAF and which objectives that they relate against. But if we just look at the individual risk pages that follow that, a couple of things that I've sort of worked on. One is to align the controls and assurances against each other. This enables us to be clear in terms of what controls we're currently receiving assurance against. It also helps us to understand where we might want to look at further assurances for those particular risk areas. I've also looked at target risk scores, worked with all the directors and the key leads around sort of what those target risk scores should be. There is a sort of a criteria how we do actually define that, and part of it's driven by the system. So where we are identifying further actions that we need to take, it does ask us then to evaluate what the impact of those actions will be on the risk score, which helps us to then drive what that target risk score is going to be. But other elements around that might be in terms of, well, what will the impact of us receiving further assurance against some of the controls, and how that might give us greater confidence to reduce the risk score down further, and therefore look at what our target risk score is going to be. The other thing, just to note point, is I've just emphasised a bit more around the conclusion section, which just sort of therefore gives you an underlying sort of just a statement really in terms of where the risk is and where we're going with that, and why we've actually got to the point that we're at. Otherwise, it's open to you to any particular questions around any of the risks. So,
just briefly, yes. We've done quite a lot of work on making sure that the risks accurately describe what it is that we need to be worried about, and that we're really clear. I think the next step for us really is to make sure that we thread the quality agenda throughout the risks so that they're visible, not necessarily as a separate quality risk, but what's the impact on quality of a financial risk or a commissioning risk or others. And I think there's a useful piece of work that we can do around that.
Yeah. So I was going to comment on that, because I saw it as well in the Integrated Governance and Quality Committee, and I know how much work is going on, and it's still work in progress. But when I look at the extract that we get here at board, it is the top end of all of the stuff that we see at IGQC, and you see even more of the risks, don't you, in the other quality committees. The word quality doesn't appear on this. It's got poor outcomes. I don't think that's necessarily does it for me. I would like to see somewhere in the, I think we need to have the word quality, and that's reflected in this. So that was the first thing I want to say. The other thing was just on risk 111, the first one. I think that might be is so loaded that it probably it fails to be useful. Really, I'm not sure. I think it maybe just bears some further discussion, because it's saying if care isn't integrated across health and care providers, and STP activity shifts are not delivered locally, then you might have financial. So I don't know whether that's two different things actually.
So I think what we're dealing with is the fact that the risk first came onto the BAF when we were still in a slightly different way of describing things, and typically we would leave the wording of the risk as it is and then track through the controls. What we may need to do in this circumstance, because it's kind of lost meaning in the context of how we're doing things now, is actually update the wording of the risk to say actually this is about the delivery of our local health and care plans, isn't it?
That would be helpful. So more work on that. And then the other thing was, and this I accept that it may simply be my perspective as to high up on our risk register this should be, but I think it's general practice, and I'm really concerned about the rest of the system if general practice is not properly supported, and we're doing all the things to manage that. And it may be that we are, which is why I know it appears on the risk register elsewhere.
Exactly.
But I just think when I was looking at this, I just thought, gosh, that's so high on my overall worry list. Why isn't it here? But so could we just review? And I accept if it doesn't fall into the top echelons of it, then that's reasonable if you've looked at it. Thank you. Anyone else have anything to say on that? We know we chewed it over a lot at IGQ, so good. Thank you. Thank you, Fraser, for all the work you've done. Oh, Chris, sorry, yes.
Just on 99 and 113, not so much about the detail of the risks themselves, but I think what came out to me from this analysis is in fact the limits of our mitigating actions. Almost everything, and just taking into account of what you said about 111, maybe the terminology isn't reflected correctly, therefore that's where. But if you look at these two have high risk to start with and still have high risk, despite the fact we're trying to do some mitigating, which suggests to me that in fact there is a limit. Of course there's a limit, but actually this proves the point. There are some things we can't mitigate.
No, we can't mitigate.
Well, I think that's quite important.
And therefore you'll see from where we look at the target risk scores, some of them you're not going to get right down to a low level because we recognise there's only an element of mitigation. Yeah, it is.
I think the only thing I'd say about 99 is that you go back to the performance report and you think, well, actually we've improved 7 percentage points year on year on A&E. We're potentially within 1 to 2 quarters of St George's returning to RTT reporting, albeit we then have to tackle the issues within what the RTT reporting tells us about waiting times. And actually, I think we should look again at potentially look again at some of the progress we're making, because maybe we're not fully reflecting within the residual risk some of the really great work that's been done to actually tackle some of those issues.
Good. No, thank you. Thank you for that point, Chris. Okay, thank you. So we've got summary minutes from Finance Committee, IGQC and Audit Committee. Anything anyone wanted to flag or raise from those? No? Okay, thank you. We had no AOB. Can I give anybody here, thank you for coming today, the opportunity to ask any questions of the board? Either of you? Kate, yeah.
I don't have a question. It's more a comment, and I probably won't be able to phrase this very well, but I'm very aware of, there's been a couple of mentions of voluntary sector organisations and social prescribing, and particularly in relation to mental health support and focus this time. There are so many varied and specific charities and community organisations that work within Wandsworth, and they're very committed, very free to you guys, and I think underused. And I think within the commissioning intentions, I know that they're not being commissioned, but I would like to see some reaching out and acknowledgement of the fact that we have got all of these resources, which, as I say, at the moment I think there's a disconnect between the statutory organisations and the voluntary community sectors. Some of it comes in with the co-production stuff that Malik's doing, but he represents one group of community organisations. There's a lot more out there. I represent an organisation called Home Start, which is across Wandsworth and Sutton and and that provides parenting, befriending, long-term for people between 6 months and a year. We've got demonstrated outcomes, proven outcomes for mental health. We've got specific projects with perinatal mental health, children who have learning disabilities, etc. We've got cookery programs to reduce childhood obesity. There's lots of stuff going on. And we feel that there isn't, not just my organisation, but lots of others, we feel there's a bit of a disconnect, and I wondered if there's any sort of consistent addressing of that set of organisations.
Josh, do you want to?
Yeah, so I'll try and keep it relatively brief. So there's a couple of things that I'd say. One is in the Wandsworth Transformation Group, which will be the body that seeks to deliver the local health and care plan. Wandsworth Care Alliance are a member of that group, so we're hoping that will help strengthen their role to act as a bit of a channel for some of this coming into the rest of the sector. We've also supported for some time the voluntary sector coordination project, which has been very successful. We're currently in discussions with local authority colleagues about how we build on that and develop it further, and we will be coming to talk to people within the sector about how that could be strengthened, and then built into a case which will go the normal route that these cases do. I think it's a reasonable challenge around the articulation of commissioning intentions, that it's not just about what you're commissioning, it's about how and who with. And in the same way that we've often talked about development of, say, the primary care sector, there is possibly a gap in our articulation of our strategy around the voluntary sector, but it's not to say that we're not doing quite a lot in Wandsworth already, but it's a really good comment, thank you, and maybe we can catch up afterwards.
Yeah, appreciate it. I think we all always need to be reminded to use the assets at our disposal, really, and I think we're very grateful for the work that people do, which is often unseen and unheard, actually, but we do know it's out there. Thank you. Very good. Okay, thank you very much. I'll bring the meeting to a close. Thank you all for your input today. I think that was an extremely good set of papers that we had, a good set of reports, so thanks very much to the team. That was really helpful today. Lots of work done.